you to our webpage. So this is our webpage where we have the recordings of all of our previous webinars, and we also have training resources on the same page. So all you need to do is to scroll down. Another useful resource, if you Google WBG OLC, this is World Bank Group Open Learning Campus. This is where you have our free online trainings, and they're self-paced, which means you can stop and go. And we have 10 trainings so far. And they're available to you free of charge to enhance your healthcare quality knowledge. Now, another web page that we have is IQ Healthcare Tool. So this is also one with the web page that shows what we do, how we work with our clients, and what are the benefits and what are the outcomes of our work. If you go to YouTube and Google IFC IQ Health, this is our web channel where you have broadcasts of our latest webinars. So if you want to know the recent, to see the most recent ones, you go to IFC IQ Health YouTube channel. So you Google IFC IQ Health. So that's it. Now a little bit about our online trainings. There are 10 of them in total. We've got a series of 7 on the basics on international patient safety goals and patient isolation as an additional one. And then we have a series of 3 trainings. Let's see if I can move it here. Yes, I can. So we've got 3 trainings on quality management. That's quality management, incident reporting, and performance management. Now, the good thing about those trainings, you do get a certificate of completion from those trainings. And to find those trainings, you go to WBG OLC, Open Learning Campus. This is where they are. Now, a few features about today's webinar. One of the things that you can use is the interpretation. We do have interpreters available, and we have French and Arabic. And where you go to find your interpretation button on the bottom of your screen. I mean, of course, depending on what kind of Zoom reflection you choose. So we've got it here, and you can choose French or Arabic. Another useful feature, let me put it here. Yep. There we go, is questions and answers. This is where you can ask your question, and we will look at it, and we will try to answer it during the webinar or later on. But the best way to ask a question is to type it in Q&A. And there's also a chat, which is not to be confused with Q&A. This is where you can introduce yourself or say something or present an example, something very brief and something that does not absolutely require a reaction from us. So that's it. This is where. So interpretation, chat, and questions and answers are your 3 buttons that you can use. And at the end of the training of the webinar today, we will have a survey on exit, just 3 minutes to let us know how how you liked it or what you would like to know more, or you can email to us responding to the email where the invitation came from. And we love to hear from our participants. This is what we work for. So basically, this is what we would like to have in exchange for our today's webinar is your opinion. So thanks a lot. And then we go to today's webinar now.
Thanks a lot, Natasha, for your wonderful introduction, as always. Hello, everyone. Welcome to IFC series of webinars. Exciting topic today. So the topic is, do investment in quality improve your financial health? And we have a wonderful panel of experts today. And let me briefly tell you about the background of the whole story, why we decided to talk on this subject. So one of the most common questions when we recommend changes to the management is, okay, so after I implement all the changes in quality that you recommend, will I get more patients? Will I get more money? Will they bring me more money after these changes? So globally, if we tried to find any information on this, the resources are limited, and very few actually companies did this research. So how quality improvements convert into profit, into into revenue, because every business is supposed to be profitable, of course, safe, but also profitable. So that's why we thought we need to change that situation with your help, with help of hospitals all around the world. And we launched our contest, which was called Business Case for Quality. So many of you probably heard about it. Some of you maybe never heard about it, but the good news is it's going to be another round. We expect it to happen by the end of this year, and you are welcome to participate. So we will follow with the description, invitations for this participation later on, so we can send it out, and also we will be making it public in the social networks and our community of practice. So that's a reason to join if you haven't yet done so. So we did the contest, and we had wonderful winner, that is Avenue Healthcare, and also we have the runner-up, and also we had other marvelous cases that the participants presented, over 30 in total from different countries all around the world. It was very difficult to choose. We were struggling. And today we're going to discuss this topic in more detail, and we thought it will be exciting for you and interesting, so hope you will enjoy. So I'm happy to introduce our first speaker today. That is the winner of our contest, Penina Kirea, and she's from Avenue Healthcare in Kenya. So Penina, you're welcome.
Thank you, Julia. I'm happy to be here this afternoon, and good afternoon, everybody from Kenya. I hope I'm audible enough. So my name is Penina Kirea from Avenue Healthcare. I work as a chief nursing officer who is also in charge of quality at the organization. So allow me to share my screen. Kindly confirm that you can see my screen.
Not yet, Penina.
Not yet?
Not yet, Penina.
It starts.
Okay,
Now
yes.
we can see, but please go to the presenters mode. Yeah.
Yes, that's great.
So I hope that you're able to see it clearly now.
Yes, we can.
So good afternoon once again. My name is Penina Kirea. I work for Avenue Healthcare as a chief nursing officer who is also in charge of quality in the whole organization. So from the introduction, of course, Avenue Hospital has been on a quality journey that started way back from 2018, the year 2018. And of course, a lot has happened within the organization. But for the purpose of this discussion today, I want to showcase some of the strategies that we've been able to put in place to address some of the issues that we've had and concerns that we've had surrounding safety of patients in our hospital. Without forgetting to mention that some of these strategies, of course, together with so much more that we've been able to work on, also I've seen us also get accredited by COSASA, which is in full Council of Health Services Accreditation of South Africa. So it is a success for us. So I'll go straight to the presentation. So I will be taking you through prevention of patient falls in the hospital, and this is the project that we were able to showcase and present at IFC Quality Conclave, which saw us get the award. And according to WHO report, April 2021, hospital-related falls are the second leading cause of unintentional injury death worldwide. So I'll not go into details on that. That was just to introduce, to show you that it is not a problem only at Avenue Hospital. I believe this is a problem that is happening in most of the healthcare facilities, but without measuring, then we'll not be able to know whether you have a problem or not. So I'll go to the next one, which is a problem statement. What is the problem and what was the problem at this point at Avenue Healthcare? This was just one of our, Parklands is one of our facilities amongst 3 other facilities that we have that are full-fledged hospitals. And we also have about 17 outpatient centers. So all of them, of course, we've embarked on a quality journey, and standardization of quality is happening in all the facilities. So between the month of January to March 2020, our hospital recorded a worrying trend of patient falls, some of which, of course, ended up being resorting to very serious patient harm. And this is at this point is when Avenue Hospital came up with strategies to reduce falls, because our data was clearly suggesting that we had a problem that was increasing. So the aim of this, of course, was to identify the cause of falls within the hospital and suggest workable interventional strategies that then would lead to reducing patient falls. And we worked on quite a number of strategies, but of course we were focusing on international patient safety goals. And of this purpose, for today's purpose, we picked on IPSG number 6. So this graph here shows you how the falls were increasing from the month of January 2020 to March. And this is not the only period that we had patient falls within the hospital, but within these 3 months, we really had quite a number of cases that costed the hospital quite a lot of money and, of course, other issues that I will be mentioning within the presentation. So from the baseline review, it shows that between January and March 2020, the rate of falls within the hospital sharply was increasing from 2.69 to 11.1. That is per 1,000 inpatient days. And most of these falls, of course, were occurring in the inpatient areas. That is the wards where patients were admitted. And amongst them, most of them, again, were occurring within the geriatric patients that were above 60 years. And the falls, most of them resulted in very severe injuries, which I'm not going to get into details to discuss. And I'll go straight to the next slide, which shows now what did we do next? We had to get deeper and understand exactly what was causing the falls within the hospital. And we decided to use this tool called a fishbone, amongst many others, including 5 Whys and all the others. But for the purpose of today's discussion, I'll just be focusing on fishbone. So in the process, we looked at 4 areas, which is process, equipment, personnel, and environment. So for the processes, we worked on, what we identified what the problem was, that we had unavailable fall risk assessment tools, no orientation for patients who are admitted in the wards, no system of fall risk assessment, identification and labeling of these patients was also not being done. Then the guidelines, fall precautionary guidelines were not available. So for the equipment, of course, we were looking at our beds, which had no rails. So patients were just being admitted in a bed. And if one of them had a risk of fall, they would just fall. So there was also no call bells. We had, if they were there, some of them were non-functional, broken, and inadequate ambulatory aids. Personnel, we were looking at staff. These mostly we were focusing on nurse-patient ratio, which was inadequate, then insufficient knowledge on fall prevention. For environment, we identified slippery tiles, and especially within the bathroom areas where patients were taking their showers and most of the time, this category was falling. So I'll go again to this slide, which discusses the causes of falls. So for the caregivers, we associated this with an inadequate staffing, competency levels were low, high attrition rate for nurses, and staff satisfaction. Of course, when nurses are overworked, healthcare workers are overworked, their morale goes low and they are not able to give services as expected. So for the environment, again, for the slippery bathroom, that one I'll not go deeper into discussing that for the interest of time. I'll go to the next slide. So this slide here shows you the severity of falls that were reported within the hospital. And from the month of January to March again in 2020, that is how the graph was looking like. Of course, you can see the increase all the way from 2 to 40. 40, that was the total number of cases that we recorded within that period of time. And the next part here is showing you the cost that was associated with the falls. How much did we consume as a result of these falls? Just to mention that the cost that is indicated here is in Kenya shillings, that is 20 million Kenya shillings. This was what was paid out as a result of damage, paying for damage, either through the court or outside court. And then 5.5 million Kenya shillings. This one, again, was the cost of taking care of these patients, because when they fall within the hospital facility, then the organization or the facility takes care of the costs. So intervention, we addressed according to the problem that was identified. If it is, when we're looking at a nurse to patient ratio, high attrition rate, of course, we looked at number of nurse-patient ratio, which is nursing hours per patient days. We were working with about 6, that was overall. Generally, they were coming to 6 hours. So meaning we were really not giving a lot of attention to our patients. Then the attrition rate at this time was 14%. Then the competency level of our nurses and our doctors was wanting. And this, again, we were able to work on a lot of trainings within the organization. Then proper handover of patients between shifts was not adequate. Low staff satisfaction, again, from the description that I've given up in the previous slide. For the processes, we were looking at non-compliance to processes and guidelines, which was happening a lot. Yes, we had worked on some of them because the journey of accreditation requires you to come up with all these policies, but we realized, yes, they are available, but again, a lot of non-conformities within these processes and guidelines. So this is a continuation of interventions and implementation. Then slippery wet floors, this was addressing the structure of the building, which meant now that we were going to change all the floors, because previously we had very slippery floors, not even within the bathrooms, but within the facility itself. Then that was addressed. Then the equipment, faulty beds, of course, we were able to purchase beds that had rails, and this addressed the issue of falling. Patient not summoning for help. This, again, we identified the issue of patients not being oriented sufficiently within the environment that they were being admitted, which was, again, worked on, and this was a success. So this slide here shows you the planning that we did and the timelines, exactly what we were able to address and the timelines. And then the amount of investment, I know this will interest you a lot. For the structural adjustment, we were able to spend approximately 12,500 USD for equipments. We were able to invest, to spend 85,000 USD. Recruitment of and orientation of training costed us 67,000 USD, and total was about 170,000 USD. So this slide here is showing you how then, after investing in all this and addressing the gaps that we had, the continuous improvement that was noted within the 3 years. So the cost of fall within 2020, that is the year 2020, was about 25.8 million Kenya shillings. And then the cost of fall within the year 2021 was about 2.8 million Kenya shillings. And as we progress to 2022, of course, it went down to 800,000 Kenya shillings. And as it is right now in 2023, from our substantiated claims that we already have, is costing us less than 500,000 Kenya shillings. So some of the results that are measurable and recorded are, as you can see, the first graph here shows us how compliance of IPSG number 6 was looking like. You can notice the year 2020, that is blue. Of course, from the month of January to March, it shows no recording at all because we did not have any data to present. We were not able to measure within this period because we had not gotten enlightened about it. Then from April, you can see the continuous progress of the blue, and up to December 2020. Then the orange color shows you the year 2021, and the year 2022 is the green one. You can see over time, we were able to catch up with conformities within that IPSG number 6, which is a prevention of falls in the hospital. So the next graph here shows you, it's just a replica of the first graph. But again, now here over time, you can be able to see an average of compliance in the year 2020 was about 45%, 2021 was about 75%, 2022 about 86%, and as it is right now in 2023, we are averaging above 90%. We hope to continue improving. So this graph here shows you, again, it's just a description of what I have already mentioned. The blue color here shows the fall rates within the year 2020, and the target, which is the red one. You can see how much we were able to record within the year 2020, and I'll show you the progress that we made in the year 2021 versus 2022, sorry. So the blue color is showing you the rates in 2021, and the improvement that we were able to make in 2022 is the red color. Then the target is the green one. So over time, you can see we started on a very high note of increased fall rates. And as we put in our measures, mitigating measures, and constant measuring and addressing the gaps, we were able to go up to almost zero. So this slide here shows you the average. These are some of the measurable results, again, that I'm able to showcase. Once we were able to address these issues within our facilities, our net promoter score in the year 2020 was 45%, 2021 was 58%, and 2022, 75%, and as it is right now, we are averaging at 85%. This clearly shows you that something has been done, because basically when you're asking, when you're recording NPS, that is net promoter score, you're measuring the satisfaction of these customers. And basically we are asking them, would you refer someone into our hospital? And this is how the results were looking like. I'm happy to also report that in our net promoter score right now, we have made a lot of progress, because we can be able to run this on all our screens within all the service delivery points. Patients are able to read what we are doing, and if they have a complaint even within the wards, they are able to raise, and problems are addressed real time. So this is a step we've taken. It's quite a bold step that we've taken, which I know many organizations will not want to go into that. So for us, because we believe in transparency, we are able to show what we are doing. And even if a patient is complaining bitterly, or maybe we do not have anything to hide on what patients complain about, because we are ready for change. So for the financial year revenue growth, this is also something that I needed to show, because in the year 2021, after now identifying all these areas and investing, then the financial growth, this is how it was looking like. In the year 2021, we were able to record a growth of 10% from the previous financial year. Then in the year 2022, we were able to record about 15%, and right now we are above 20%. So clearly you can see that out of this is correlating to the Net Promoter Score, what customers are saying about us. And what makes me, what keeps me encouraged is just to know that a happy customer, a happy customer will only tell 2 people that they're happy. But an unhappy customer will always tell so many people, and we rate it as about 10% or 10 people out of. So you can clearly tell that bad news normally spread a lot more than the good news, and this is what we are working with right now. It has been a success for us. Then how do we sustain this? I'll be looking at just 2 major areas so that I don't consume a lot of time. So we hope to, and we are embarking on embracing innovation and technology. Amongst these is one of the incident monitoring and management system called MedBlaze. We are introducing this within our organizations, and it's going to help us so much in capturing of data, analyzing of data, and just help us in real-time reporting from all the facilities within the organization. And we believe that this is going to be a step further for us to address safety and quality of care within the organization. Then we hope to also introduce Kaizen, and it's already in the process, which is continuous improvement. Basically, this is going to cascade our strategy, which is to offer quality of care to all our patients that come to our organization, to basically daily, weekly, monthly, and yearly, activities that we need to be working on within this period of time to be able to realize our, which will address our strategy and attain safety of patients. So the next one, this is departmental fall indicator monitoring that is happening right now within the organization in all the departments. I will not go deeper into discussing it because it will consume quite some time. You can clearly see that if this tool is well addressed in all the departments, then it's able to give you a view, or basically it will be able to give you information on where you are at as an organization. So conclusion then from my presentation is that data that is accurate aids in decision making that ultimately leads to a great customer experience. A great customer experience leads to a happy customer, brand loyalty, and higher revenues for your business. The second point is that incident investigation and management decreases extra healthcare costs to both individuals and overall healthcare system. What this means, if you have those incidents that are costing patients, they normally end up costing patients a lot of time. If a patient is admitted in the ward for 3 days with an expected length of stay of 3 days, then when they have these incidents like now the falls that I've been discussing will mean then you retain this patient for more than 30 days or so, and that costs them extra money. And if it's not the patient and the hospital is willing to take care of the cost, then the cost is very high for the hospital. Then healthcare projects and programs are good a good place to start in enhancing the culture of safety in the hospitals. In addition, these programs safeguard the hospital from litigations arising from adverse and sentinel events. So what I mean by this is that, when you have these quality metrics in place and you're faithfully monitoring and addressing the gaps, then they are able to, you're able to enhance the culture of safety within the organization. And again, this increases a lot of loyalty from your customers. And in the long run, then the hospital is also not going to lose through litigations, because right now, I don't think there's anyone right now who is not enlightened on what their rights are within the healthcare facilities. And that, most of the individuals right now, if they are not happy, they are all running to social media, which at the end of the day ends up tainting your hospital badly, and through bad reputation, then you end up losing business. Then 4 measures are simple and they enhance health and improve confidence in the healthcare services. So what are the lessons then learned within this presentation of mine that I did? The management or leadership of the organization is very, very, very key in promoting organization-wide quality improvement plans. So this means then the leadership, if you do not have leadership support within the healthcare facility, then you're not going to achieve quite a lot. From my own experience within our organization, we have a lot of support all the way from the board to the CEO and to the senior leadership team. And this means then even financing some of the projects that you put in place are going to be successful. Then key stakeholders involvement. This meant then the policies addressing the gaps that were noted involved everybody. You have to involve everybody within the organization, from bottom up and top to bottom, for you to be able to get buy-in from the staff, because at the end of the day, these are the people who are going to implement the strategies that you put in place. So they must feel part of the conversations and the steps that are being taken. Close monitoring, this is again data collection and monitoring. This is going to give you a lot of insight of where you are. If you don't measure, you do not improve what you cannot be able to measure. So this was one of the learnings as well. Patient-family involvement, this is very key. If you do not involve the relatives and family, then at the end of the day, when these incidents happen, they do not know exactly what. So they feel that there's a lot that is being hidden from them. And at the end of the day, how they handle an incident that comes up, then it's determined on how much information they had within the care that was given to their clients. Then staffing, of course, that one I've discussed quite a lot within the presentation. Consistency is key, and timely feedback to all the team players, including the healthcare workers and the relatives. So now we go back to the big question. Do you think from my presentation that quality investments improves financial health? I leave that to you to make a decision and to answer the question. Over to you, Yulia. I hope I did not take a lot of time. I was really rushing to make sure that.
Thank you so much, Penina. This is a wonderful case, and I'm sure everyone would have been excited to learn more about it. But unfortunately, we have all these time limitations. So I'm sorry if we kept you stressed because you had to rush, but I'm sure we will have time to discuss this big question today during question and answer session. And before I introduce the next speaker, actually, I was going to say that this is a very inspiring case, I think. So I hope you also found it inspiring. And also in IFC, we have a benchmarking service. So if you want to compare, which is free of charge, if you want to compare your financial and your quality indicators, there are lots of them in the program, then you can participate in it. So now we are collecting applications for it. So please just let us know, send an email. You can send an email to Julia, Julia Afrakova, who was actually sending you an invitation for this webinar, or let us know in the chat that you would like to participate. We'll get in touch with you and tell you more about the service. And speaking about this Penina's case that Penina described, the Avenue case, it's interesting fact, fall prevention or international patient safety goal number 6 is usually one of the weakest areas based on our observations. Patient identification or hand hygiene are known to many, but this seems like a very dark area for many hospitals. So this is a great example that sometimes sources of profit or sources of cost reduction or revenue growth are not on the surface, are not that obvious. And root cause analysis and good structural thinking can help you identify how to make your daily practices not only safer, but also more profitable. So now we move to our next speaker. This is the runner-up in our contest, and that's Javier Lozana, the co-founder and the CEO of Azucar Clinic from Mexico. Javier, we are excited to hear your story.
Hello, everyone. Good afternoon or good morning. Thanks, Julia and Penina. Very nice case. I really like one of the sentences that data that is accurate. It's in decision making that ultimately leads to a great customer experience. So I think amazing the job that you all have done. So let me share the presentation. So we are Clínicas del Azúcar, and we are the largest provider of specialized diabetes care in Mexico. And I will speak a little bit about the company, how we were structured, because we were basically aligned for process improvement data for the patient engagement, and then the specific case that we submit about how to cut the prescription errors and cost for patients. Okay, so first, I think something that makes us very unique. We have this big dream that that diabetes typically, or at least in Mexico, and I know in every country now, it's a catastrophe. I mean, the increase in the prevalence number of people, and in Mexico is one of the main causes of death, amputations, kidney failure, blindness. So definitely, I mean, it's a disease that is becoming really a burden for people. So our big dream is that diabetes is no longer a burden, and everyone has access to specialized diabetes care. The injustice for us is that in most of the emerging markets, if you have money, you have access to specialized care, in the probability to get complications, it might be around 4–10%. But if you do not have access to specialized diabetes care, your probability to get complications might go up to 60 or 50%. So definitely money is a predictor of your well-being. And we want to, that's the injustice that we want to solve, and making diabetes, and especially easy and accessible. One of the things that typically happen in healthcare is that innovation increases cost, and we're always looking for how the innovation will decrease cost and make it more accessible. And so how is the Clínicas del Azúcar model? And just very briefly, well, I was in MIT doing my master's degree and doing a lot of courses at the Harvard School of Public Health. I come from the manufacturing and retail background, and I was a master black belt for Six Sigma, process improvement, strategic planning. So when I start just looking as a hobby, my passion is just how technology improves people's life. So just as a hobby, that I was doing some projects in around diabetes care, and eventually I talked to my mom about her diabetes, and she shared that one. The first thing is she said, "I'm exhausted, and I have to go from one place to another one, and a lot of information that she has to handle. Cost was another important, and then also she shared that, I mean, as the doctor was putting a lot of pressure on her, like, you have to lose weight. She will try, she will fail, just as many patients do. then she will come back and the doctor will blame her that she's not trying hard enough. And she will try it again, fail. So eventually she didn't become depressed, but it was kind of like sad, and almost she felt like, you know, I'm not good at doing this change in behavior. So that was to me and she shared that she didn't want to get care anymore. So that was my aha moment to say, why, if we have great doctors, great medication, great knowledge, why still diabetes care is so difficult for patients? So that's where the idea of Clínicas del Azúcar came, to completely revolutionize the way we provide it. And it was 3 pillars that we set. The first one, and we started in 2010. So the first one was to create a one-stop shop. And I was fortunate that Dr. Clayton Christensen, I was a part of one of his classes and a great mentor, and always struck me his concept of the job to be done. So typically in healthcare is the job to be done from the clinic or the doctor perspective, is what the clinic needs to know, what the clinics needs to do within the patient. So when the patient comes to the clinic, is everyone looking at what they need from the patient. But if you look at from the patient perspective, on the other side, it's a very different job to be done or needs from the patient. So the first thing we did was, from the patient perspective, what the patient needs to do or wants to accomplish in a year. So we set a process, and then we say, can we put it in one place to create this one-stop shop? So I will just give you a brief of how the Clínicas del Azúcar one-stop shop works. And so instead of the patient going to the doctor, to the diagnostic lab, the nutritionist, a retail store to buy diabetes-related products, the pharmacy, the patient basically comes to the clinic and then go through different stations, about 7 stations, 15 minutes per station. So in 1 hour and a half, and the patient goes to equally 6 or 7 consultations, and this reduces cost and time by more than 75%. So that's the convenience, and just also a few pictures of just how the patient goes from one station to the next one, and just how the clinic look like. Very retail. We are next to supermarkets to make it very, very convenient to the patients. So and now we also launched our last year our virtual care, so the patient can do their journey in the clinic or virtual. The second important piece was the fixed fee subscription, and I mentioned this one because we were aligned on the quality and make the case why it's so important for us, process improvement and quality for financial health. And because we were the first ones to propose a subscription model for chronic care, and one of the reasons is we were very aligned with the patient to optimize cost. Typically in a fee-for-service, providers are incentivized to provide more care because that means more revenues. For us, it was we took the risk, and so the first thing we wanted to do is we need to control patients as soon as possible and at the lowest possible cost to get our profit. And on the other side, from the patient perspective, also give them certainty. As you will see on a different slide, most of our patients are middle and very low income. So having certainty of how much I'm going to pay per month, and just give you a typically, say in Mexico, to pay for traditional private care, you will have to pay about $1,000 per year. We charge $25 a month or $300 a month. And so for people, it's very transparent, $25 a month. Everything, it's unlimited and included. And we help the patient also to navigate what their care needs. And the last piece that was important, and just to do an echo on what Penina mentioned, is since day one, we were strongly believers that data was going to be the way we could optimize and segment and provide a much better treatment. So we capture more than 2,000 variables per patient, and continuously we are comparing within clinics, within specialties, within archetypes of patients, and we have done a lot of implementation of AI to predict what the patient behavior is going to be and optimize the treatment. And I will get into more detail about it. And so just how the expansion has been and why data and quality has been very important to us. And we start mentioning company in 2010. We opened the first clinic in 2011. By 2013, we replicate within one city. So it was a very successful pilot clinic. Then we replicated in different areas of the city. Then in 2017, we said, well, let's scale in the north of Mexico with 12 clinics, 60,000 patients treated. By 2019, we said, let's go to another region of Mexico. So we went to the central west with 15 clinics, 150,000 patients treated. And then starting in 2020, we accelerate as we were able to optimize, monitor, and make sure that the quality was in place, because I think what my biggest fear in our expansion is that we can lose the quality and reputation. You know, you have all these examples that being one or two clinics or a few thousand patients, they were great, but then as you grow and a lot of providers lose their quality just because of so many problems arise and how you control and monitor. So that was one of my biggest fear in making sure that everything that we have done and could be replicated. But once we were in 2020 very comfortable with the tools that we developed, we were able to accelerate our growth. And we went from 3 states to 17 states and 37 clinics, and also launching the virtual clinic. And just in a picture, this is where this is Mexico, where the states where we are, and the number of clinics. And also, as you can see on the graph below, the number of consultations per year. This year we're going to be over 1 million consultations. So we went from 200 people in the organizations to 700 in just 24 months. So always the concern for me and for our chief medical officer is definitely how to maintain quality. I mean, everything has been done amazingly and on the impact side, on the access, but how you maintain quality, and also as new people is coming into the company. And with that, we were now able to develop a model to open a clinic in just 7 weeks. It's a very precise process of how we locate, remodel, train, and launch and open the clinic. We have now also a platform that we monitor clinics in real time. I have more than 50 KPIs for the executive team that we review daily, weekly, and monthly. So when a clinic for every KPI becomes an outlier, very, very quickly we can see where the problem is. So that allows to, even that we are very spread out across the country, we are able to very quickly make sure that, and when we have a problem in the clinic, first we try to solve it with the clinic manager. If it's a problem that could not be solved within the clinic, we have a special team that goes there for a couple of weeks and make sure that the problem is solved. And lastly, we have 94% net promoter score. So just like Penina mentioned, we are 100% out of pocket. Patients pay directly. So the patient experience, it's very, very important to us because it's private care. So in the first time that you do not provide or meet the expectations, definitely patients not only will promote it, but also, they will talk badly about the company. And going to how we are organized and then to the specific case that we present. So how we structure the process improvement in the company. And I just want to mention, I ironically mentioned, and when we start, that we were going to be the McDonald's for diabetes care. And I know that, it sounds very odd how McDonald's plays have a place in the healthcare industry. But something that I really admire about the retail industry or the fast food industry is just the way they use technology for process improvement and standardization. I mean, when you go, when you're traveling, I was just traveling last week, and I was in a rush to get into the plane. I just had a few minutes to board. Then I saw a restaurant, long line. I said, you know, it's gonna take forever. And then I saw McDonald's with a long line, but I said it's gonna take 2-3 minutes to get my burger. And indeed, I got it 2-3 minutes, and that burger tastes exactly the same as it tastes here in Monterrey, Mexico. So one of the things that to me always admire and struck me about these companies is how they are able to provide the same service or the same product at a very low cost in every part of the world. And to me, that's also the key. And in the work that we do is how we make sure that every clinic is able to provide very good care in a standardization mode. And at the same time, how we automate the personalization, how every patient is different, and how we are able to segment that. So how we do it. So the first thing we do is data. We capture a lot of data from, we serve 3,000-4,000 patients a day, capture all these variables through the year. So we always, everything is captured from we have a patient support center that reach out to the patient after they come to the clinic. So all the data is recorded and is electronically. And then we have a special team that are working on data segmentation and analysis to determine behavior. We create archetypes. And I believe that in diabetes care, one of the biggest failures is that we think everyone is the same. So we have the same clinical guidelines. If you are 40, you are 70. So we always start looking at, okay, how we can better segment and different type of patients, different type of clinics, different types of, even within the specialties, why some doctors have better control rates than other ones. So always looking at having these clusters to analyze the data. And based on that, we design specific interventions. And then we run algorithms and machine learning for always get to better understand and build our predictive models. For example, we have a model that predicts which patients are going to reduce their glucose levels or not. So the specific example that we wanted to showcase is because most of our patients are low income, one of the critical factors on where people that were abandoned their treatment was the cost of their medication. And what we learned was that patients mostly or typically are very afraid to tell the doctor that they do not have money or they cannot afford to buy certain medication. So the patient will come into the doctor will say, and I have different type of medication. Some are more expensive than other ones. Sorry. And are you okay with that? And the patient will say, yeah, it's not a problem. So the doctor would try to give the best medication, and then the patient will not come back. We will call the patient later, and the reason was, you know, the prescription is so expensive that I cannot afford it to buy. So what we did was we, based on the income level of the patient and a couple of more variables, we create a specific medications or clinical guidelines per patient. So if the doctor have a low income, very low income patients, they have only a specific medication that can prescribe. And if the patient has well, first we map the whole country. So we have the income levels of every address. So once we get the address of the patient, we know exactly what the income level is, and we can personalize these medications. And then the first thing is, well, we did chief medical officer did the guidelines and a lot of training on how they were going to manage the different income levels and the medications. So the first thing that and also what we implement to make sure that we could have a tool to monitor that was, So the electronic health record opens the medication that they can prescribe, but of course we can never limit the doctor, as they are free to provide their care that the patient needs. So the doctor could prescribe an additional medication, but if it was out of the range, they will have to give the reason why. And sometimes it's, for example, they maybe their children are paying, or the whole family are paying all together for a medication, and they want a much better medication for their mom and dad. So the first month that we implemented and started measuring, 12.7% of the prescription were out of the range, were different than the system recommends, or the and here the chief medical officer started a process of look at that, and this is the average. There were doctors that 25-30% of their prescriptions were completely out. And so first they start looking at the chief medical compared the more than the 100 doctors that we will have, and see which ones were out of the range, and provide more training. And one of the learnings here is doctors were afraid that if they were not given the best medication, then the patient would not have good control rate. So that was the biggest fear of why they were trying to push for more better medications. And then a few months after, it was about 6 months, and as our chief medical officer were working with every doctor, then the percentage was reduced to 2.3%, basically aligning almost completely all the prescriptions to what the patient could afford to pay. And I mean, when we did it was a 20,000 investments in the software modifications, implementations, and training. And the ROI that we're getting, it's now about $260,000 per year. So we got almost $1 million already out of only this implementation, and based on the retention, the increasing retention rates. And the last, you might have the question, okay, you limit the prescriptions by cost, but are you sacrificing the control rates? And just wanted to show on the left, and this is the A1C levels. So as we can see, the initial A1C, typically our patient comes from 9.6 to 10. You can see that low-income patients are definitely with the higher or with lower control rates, and so they come at 10.15. But then after 6 months, the high-income patients go from 9.6 to 7.25, and low-income goes from 10.15 to 7.31. So even that, you know, prescription could be 1/3 or 1/4 of the cost. We now also implement low-cost menus to optimize what people can, or what we should suggest that they can eat. So now the whole chain of the nutritionist, doctor, psychologist, and all the recommendations goes to what the patient can afford. So even that the cost of care are significantly lower, we are achieving the same results. And as I mentioned, 77% of our patients are middle-low or low income. And so that's what I prepared. So just in summary, for us, definitely the way to, and one of my main recommendation is always data is so important. So always start with how we can capture data and how it could be in a very structured way. So if you get an expert in databases, and always think about not only capturing the data, but making sure that it's very structured, that what you could accomplish and what you wanted to do in process improvement. And then the next one is use the data to review, analyze, and detect where the main opportunities are for process improvement. And I think definitely the healthcare has changed in the last, and even I will say in the last 10, 15 years, because patients are looking for a much better experience. Now it's not only get to a hospital to save my life, but now is I want to get to a clinic or to a hospital and get good patient experience. They Google their recommendations, they talk to other people about also what they said. So I think for providers it's so important to continue investing. And just as now any other industry does, is very important to invest in quality, because that's the way that definitely would deliver results.
Thanks a lot, Javier. This is so true.
Thank you.
Definitely the whole world is moving into that direction, and patients get now more awareness about what good quality care should be, so they understand what to look for. And of course, in order to become competitive, for the hospitals, for any medical facility, you need to provide quality care, that's for sure. And this was a wonderful case. So you could see it actually touched two important quality and patient safety related areas, both guidelines, so structuring the work and treatment processes, and also medications. So it also reduces the risk of or side effects of the medications. And also it's important that this is a great example for those of medical professionals who think that guidelines are actually not so useful, because doctors have their knowledge, doctors of course have their experience. So what is the danger if one doctor is treating one way and another doctor is treating another way? They're both doctors, it's fine. So this shows that basically guidelines are important and can be a booster for growth of business, and can be a booster for growth of profit and also of patient satisfaction, because it creates safe and transparent environment where every mistake is easy to track. So now we move to our third speaker, and that's Panda Health Kenya. And I'm introducing Dr. Robert Coram, who is Chief Medical Officer, and the wonderful story, which is also related to guidelines, but from a slightly different angle. So Robert, the floor is yours.
Yeah, that's exactly right. Thanks, Julia. And thank you to my colleagues, Penina and Javier, for your presentations. Really inspiring what you guys are doing, and so happy to see so many people from around the world here in this webinar. What I'm going to do is, just like Julia said, we'll go a little bit deeper into the nuts and bolts of how Panda is achieving a really high level of guideline compliance within our primary care network. So I think in many ways, like I fully agree with what Javier just explained about kind of being almost like a McDonald's of healthcare. And for them, it's diabetes care. For us, it's, general outpatient primary care, which encompasses everything from non-communicable diseases like diabetes and hypertension, but also we take care of children, and we do, thousands of vaccinations every month. We take care of pregnant moms, and, we do a lot of urgent care as well, headache and bellyache and things like that. But before we get into how we do that, my name is Rob. I'm a primary care doctor, and I've been living and working here in Nairobi, Kenya with Panda Health for the last about 8 years. And what we've done is we have implemented clinical decision support tools inside our electronic health record. And I want to talk to you a little bit about how and why we did that. So first of all, this is a global problem, this problem of guideline adherence. Within Kenya, only about 40% of healthcare that's provided across the country is in accordance with national guidelines. And that's sort of comparable with what we see worldwide. I think, like Julia may have been alluding to, a lot of doctors don't like the idea of following guidelines because every patient is unique. And of course, as professionals, we all believe that we have our own, great medical knowledge. And therefore, why do we need a guideline to tell us what to do? But this is really quite a big problem. And in healthcare, we often, start with a patient story. So if you can consider a child, let's say the child called Jaden comes into the clinic with 2 days of worsening watery diarrhea, diagnosed with gastroenteritis and has some moderate dehydration. A lot of clinicians in our area sort of reflexively go to antibiotics. Oh, they have diarrhea, they need an antibiotic, done. We know from a lot of very high quality evidence that the most important interventions for that child are oral rehydration salts, given in sachets typically, as well as zinc sulfate. when it's been studied within Kenya, what percentage of children with gastroenteritis and dehydration, which is a top 5 leading cause of death in children in Kenya, less than 40% are given ORS and less than 1% are given zinc. Both of these are very affordable medications. They're, the supply chain for these medications is robust across the country. So it's really suboptimal that a lot of these kids are really not getting these evidence-based treatments. So the lack of clinical guideline adherence is leading to worse outcomes for patients. And it's also leading to wasted resources for patients, because for our patients and many patients across the continent, they're paying out of pocket for consultation, for lab tests, and for treatments. And so if they're paying for antibiotics when in fact antibiotics may not be indicated and these other more effective treatments are indicated, that's a wasted resource for them or for the health system payer. It also leads to greater variability in clinical processes, which we'll talk about how that impacts the bottom line. So what we do at Panda is we use technology to deliver really exceptional quality every time. We have a clinical decision support system, which underlies more than 90% of our patient interactions. And you can see a little snippet of the screenshot here on the right. So we have a cloud-based electronic health record. And when a diagnosis or in some cases, a complaint of the patient is entered, these pop-ups of commonly accepted guidelines appear on the screen for the clinician to act upon, either accepting or rejecting those recommendations. Then we do regular quality reviews to really see to what extent are those guidelines being followed. And we've been able to achieve 2 times the national average in clinical guideline adherence. And this month, we're at about 88% guideline adherence. We support all of this through a lot of e-learning. So we take all of our employees through some e-learning platform where they watch videos about how this is used, why we use it, and how we use this information to continuously improve quality. So I want to show you one level deeper about how this works. Basically, when a clinician enters a diagnosis like diarrhea with mild dehydration, they'll get this pop-up on the screen that includes guideline recommendations like zinc sulfate, and this is a 60 milliliter syrup bottle. There's also, we have our ORS sachets, and you can see that RX means prescription type suggestion. We also have lab type suggestions. We have some physical and history examination template suggestions. We also have patient education referral type suggestions. And then you can see a really easy interface to either accept or reject that suggestion. When you accept it, that automatically pops into the electronic health record as a prescription order or a lab order or what have you. So a big part of how we've implemented this is it needs to be that following the recommendation becomes the easiest thing to do. We don't want to make it harder to do the thing that we expect to happen every time. And just having this accept button makes it very easy to sort of pop those things in, and it actually lightens the clinician's workload. The other nice thing about this is because it's just accept, reject, and clinicians are required to act on that before they close the visit, it produces this really robust back-end adherence data. So what you can see on the bottom here is those are different medical centers that we have all around Nairobi. We have 19 in-person medical centers. And you can see the adherence data for different suggestions across those different locations. We can cut that adherence data by clinician, by location, by time period, by diagnosis, by suggestion type, like whether it's a prescription or lab. And that gives us a lot of insights into which suggestions and which guidelines are being accepted versus rejected. And I think that back-end adherence data is really important. Some clinicians and health systems are now starting to incorporate clinical decision support, but it's really critical to have the back-end component so that health system leaders and quality improvement specialists and clinicians within the organization can really know how they're doing on these things. So how has implementing this clinical decision support really impacted the bottom line for Panda? Well, it's definitely allowed us to scale our operations in a really consistent way and increase our throughput. So over just a couple of years during implementation of clinical decision support, our clinic volumes have grown, our monthly revenues have grown quite a lot. And this cuts off in, I think, the end of 2021, but that trend has continued in terms of growth. So we've gone from seeing about 160 patients per day when we first implemented the CDSS to more than 1,200 patients per day, which is now today in 2023. At the same time, because of that standardization, we've been able to reduce the pharmacy SKUs, that's stock keeping units, or basically like the number of different drugs that we have in the pharmacy, from over 1,400 when we started down to only about 420 today, which still gives us a really wide formulary to be able to take care of all the things that we need to treat at Panda. But we're treating them in a much more standardized way. So we've been able to reduce formulary while still increasing pharmacy sales over this time. This clinical decision support has led to a lot of positive reaction from our accreditation partners. So we work with the National Hospital Insurance Fund, that's NHIF in Kenya. We work with SafeCare, which is an accreditation body through Farm Access. And they've been really impressed with clinical decision support. And I think it's been, it's made it a lot easier to demonstrate how well Panda is doing in terms of guideline adherence. We've also won some awards for our quality, and I have a picture of that right here. So last year at a value-based healthcare conference with Jubilee Health Insurance, one of the largest health insurance providers in the country, we won the award for best outpatient quality. We also won the award for the lowest cost services. Two separate awards that are seemingly at odds with each other, but we were able to win actually both of those awards. And I think that recognition clearly drives volumes. And so with this particular insurer, for example, with Jubilee, that insurance partner has been, that's where we've seen our largest growth in terms of patient volumes among all of our insurance partners. And the way we interpret that is that the insurance partners want to work with companies that are doing exceptional things in terms of quality. They want to have quality services for their patients. And they want to know that the care that's being provided is in accordance with national and international guidelines. So I think, you know, demonstrating that clinical decision support has been key in growing volumes, which for most of us is what ultimately drives business success. And then here on the right, I just have a picture of one of our clinics in downtown Nairobi, which has also just grown tremendously. And I think it's not just the payers, it's also the patients who can see this increase in quality. So we have this patient feedback you can see there below that says, you know, you're not money-minded, you care about people's health, not after their money. I liked very much your service. And we get comments like this all the time from patients. I think there's a real loss of trust in the health system, particularly in Kenya, where people feel like, these healthcare providers, they're just trying to get my money. And so it really takes a concerted effort, I think, to like build up that trust. And part of what we need to do is demonstrate that we're doing the right thing for the patient's health and not just trying to make money. I have an example of that here. And so you can see, coming back to that same diagnosis in question, diarrhea with mild dehydration. If our providers prescribe Augmentin, which is an antibiotic, and I looked up these prices at Panda for this presentation, we get 1,400 shillings of revenue, which is about $10 US. If we give zinc and ORS, we get a total of 210 shillings of revenue, which is obviously much less. And so part of why I wanted to include this slide on here is to just have sort of as a caveat, quality improvements do not always result in immediate improvements to your bottom line. And in some cases, they will hurt your bottom line. And I think this is an example. You know, as we work towards reducing unnecessary antibiotic prescription, it can be painful in the beginning in terms of your bottom line. But I think the way we view it is we really need to go for those long-term gains, which are won by demonstrating to patients that what you care about is quality, demonstrating also to payers that what you're doing is following evidence-based guidelines. And I wanted to put this note here on the bottom right about how does this math change under different payment models? So NHIF and some of our other insurance payers are now starting to become more savvy about how they pay for healthcare. Instead of paying in a fee-for-service model, like I have sort of listed above, they're paying in more of a subscription type model. Also, some of our corporate clients are doing this, where Penda's getting just a flat fee. I think Javier alluded to this as well with Clinicas, is that people are paying a subscription fee. And so under that model, this math very quickly changes, where we say, hey, actually, like Penda's bottom line is going to improve by providing the evidence-based care that in this case happens to be less costly, which means more of that subscription fee is actually retained for the provider. So I think as the payment models are shifting in our markets over the next few years, the provider models that have really invested in evidence-based methods and in quality provision are actually going to come out on top, even if you may lose a little bit in the short term because of the fee-for-service model that we live in today. So let me pause there. It's been really fun talking to all of you. I hope that we can engage more over questions. Thanks.
Thanks a lot, Robert. Yeah, that's actually a great point you raised about getting worse before it gets better, because that is exactly when we were discussing these specific cases and the contest during the IFC conference in Cape Town. We used the same illusion, basically. We were discussing that it's like the dentist treatment. First, it gets really bad and swollen, but then it gets better. But it doesn't mean that something is going wrong. Actually, everything is going right. It's just a little bit bumpy at the beginning. So before we move to the next speaker, I actually wanted to thank you for being so active today with your questions and answers. And maybe meanwhile, our experts who already finished their presentations could have a look at the question and answer button section, because there are lots of questions which are directed to specific expert. So we have very big panel today. So I hope you are enjoying its intensive discussion today. So we have two more experts coming before we move to the question and answer session, because basically today we covered different types of medical facilities. So Avenue Healthcare is a hospital type. Then we had a specialty clinic, which was Javier's presentation. So primary care or outpatient care is Robert. So we thought we should also cover diagnostics. And that's why we invited Manuel Geralda to present on the conversion of quality investment into profit in the labs. It will be a very short presentation. And also you asked us when we started to send out invitation to this event. So several people asked us, will there be financial experts who can also give slightly different opinion from the other side? Does it really impact your profit investing in quality? So we will have a financial expert as well. So Manuel, over to you, please.
Well, thank you, Julia. I want to thank you. Thank you for the time. It's just going to take a few minutes. So my name is Manuel Geraldo. I hope you see the slides. Can I get a confirmation of that? Okay, I think
yes, we can see.
All right, thanks. So first of all, I'd like to thank the panelists from Kenya, from Mexico, for their excellent presentation, the excellent work in quality. My work is, I'm based in Canada, in Toronto, and my work is many years of experience working in different hospitals, in teaching hospitals and academic hospitals in Toronto. One of my latest work was done at North Georgia Hospital, a teaching community hospital based here in Canada. So why did we start a little bit of this work? I'm going to take only 5-10 minutes, 7 minutes max on this presentation. So it's going to go a little bit fast because of time and essence of time. So it is well said, not only in Canada, but around the world, that approximately 30% of it investment in healthcare is unnecessary, and it adds little value, not only in lab, but also in medications, in treatments, in procedures. 30% of that money that goes into healthcare is much in unnecessary healthcare. In the impact in healthcare, low value care obviously has multiple implications, and we already heard some of those implications, and we see literature coming all the time. Regarding the patient outcomes, we see poor outcomes because of their treatment delays, longer stays in emergency department, in patients that are discharged later because they're testing or because whatever, the diagnostic imaging didn't work properly, medications. Obviously, another big potential outcome of poor patient care is the harm that we could cause to patients and the adverse events that could come out as a result of that. And at the end of the day is patient dissatisfaction. In terms of the another component of this is the inadequate use of resources, wasteful healthcare spending, redundancy on testing and prescriptions, and poor system performance, which translate into financial implications to the organization. Bad reputation, suits, laws, issues that happen behind because of this low care that we can put into people because we're doing more than we're supposed to do. So in 2015, 2014, our hospital joined an international campaign. Some of you have heard about this campaign. Is called Choosing Wisely. And because of that, we adopted evidence-based medicine practices, protocols regarding not only in lab medicine, but also in diagnostic imaging, in medications, in procedures. So what we were looking at, implementing best practices when it comes to all the different settings of care. And we have multiple examples in our hospitals in Canada and our hospitals who have adopted these practices as far as how would that translate into better outcomes. You can see specifically for lab on this particular screen, on this slide, you'll see that before the interventions back in 2016, 15, we were doing about 28,000 tests per quarter, sorry. And you can see below the first screen, the first graph, you can see the different tests that we were running in the emergency department. So you can see CBC, glucose, creatinine, troponin, all the testing that were done for emergency patients. And then after we intervene and we implement evidence-based medicine, we were able to cut down from 28,000 to a year later, we were able to cut 28% of the testing. And obviously this testing translate into better use of the resources and at the end of the day, savings or financial gains. So this was a very good key example, and we were able to publish this as well. Again, another slide which shows that a patient is, when he goes to a hospital, there are multiple, he faces a lot of multiple interventions in radiology, in lab medicine, procedures, and how do we manage that in a proper way? So another big example that we were able to implement was testing done before pre-op surgery. And we were doing about 37,000 tests before implementing evidence-based medicine. And then we cut down to a reduction, about 38% decline in the number of tests before patient goes to surgery. And you'll see the testing that goes, and in blue is before the intervention, and after the intervention, you can see in yellow the reductions in testing. So all of this is to say that there are many gains and many quality benefits and financial benefits when you implement evidence-based guidelines and best practices. And you'll see that overall, you see enhanced quality and patient safety. You see a better patient experience, reduce harm and delays in treatments. A big example of that for LOS, length of stays in emergency department, maximize reputation, higher performance in our system. And at the end of the day, this translates into revenue growth or savings. And people ask me all the time, oh, okay, what do you do with those savings? So there are multiple ways that we look at the way. Obviously, the savings will allow us to do optimize resources. We can implement new procedures and services. And at the end of the day, we do less waste in healthcare. So 5 to 10 minutes just to show you where we have tons of examples, but I'm going to stop right now. And I'm going to go back to Julia. Thank you.
Thanks a lot, Manuel. Yeah, this is also, I think, it demonstrates basically this example which Manuel kindly provided, that basically quality is not a burden, it's actually a tool to increase operating efficiency. If you think structurally, if you identify specific problems which are chosen with the help of the root cause, you basically hit the target. You actually start to operate more efficiently. And speaking about efficiency, I'm happy to introduce our financial expert today. So that is Emmett Moriarty, who has extensive experience in healthcare generally, and specifically in financial investment in healthcare, and also in operational activities in healthcare. And Emmett actually was for some some time in IFC as a health sector leader, and also worked as a vice president in a big chain, actually the biggest healthcare chain of hospitals in Russia. So lots of interesting experience times Emmett has, and now he advises actually financial investors in healthcare. He's based in London, but works in emerging markets. So we are curious to know what's Emmett's opinion on conversion of quality investment into financials. Does it really have impact, or maybe you have a different opinion from other speakers today? That's
okay. Thanks. Thanks very much, Julia, for that introduction. I feel like I'm the imposter here. I'm the only non-healthcare quality person on the panel, but it's inspiring and hugely interesting to hear the different perspectives from around the world and the efforts that people are making on quality improvement. So yeah, as you mentioned, for the last 5 or 6 years, I advise investors, financial investors in healthcare, specifically in emerging markets. So these are cold-hearted financial people who put their money into hospital groups, healthcare groups, and want to get even more back. I also sit on the boards of some private equity invested hospital groups, one of which is AAR in Kenya. So Robert, Penina, and us, we're all fishing in the same pool. So a lot of the things that I've heard resonate quite a lot, particularly how quality and financial performance are not different things. So if I talk first of all about the way investors look at hospital companies or healthcare companies, if we go back 7, 8 years ago, I would say most of that analysis went on the financial performance. So we're looking at revenue growth, profitability, return on assets, average revenue per patient, this kind of thing. And those are still important. But I would say that the biggest difference in the way that these investors look at healthcare companies nowadays is that they are also looking at quality. So, for any of the people, who are listening and watching today, if your company is invested, is going to be sold at any time in the future, I would say there's a near 100% chance that the investment team will have some quality expert there looking at the quality of the organization. Now, when I say quality, I'm talking about a lot of the things that we've heard earlier. So things like having a quality improvement plan, what indicators are being measured, talking the vocabulary of falls, safe surgery, incident reporting, medication errors. And they're not really looking at things like, are there too many falls? Are there too many infections? Is this higher than usual? Of course, if they're really high, the answer, the question they're really asking is, does this organization take quality seriously? And if it doesn't, if the answer is no, they will quite often walk away. I've been in meetings where the meeting has more or less said, yes, we can see you're a profitable company, but everything else is opaque. We don't understand, what the doctors are doing here. We don't understand, the death rates. We don't understand, are there protocols, procedures, who's in control, and whatever. So it is very important for these investors to see that is taken seriously. And then related to that, I would say, from an operational leadership perspective, and the same goes for these investors. I'll just talk very briefly about 3 things I would say, and I think the others have mentioned this. I know Penina mentioned risk management, but quality improvement and risk management certainly go hand in hand, particularly as hospitals go into more high risk areas, like obstetrics, like pediatrics, like cancer, like complex surgery. Here in the UK, where I'm based, obstetrics accounts for about 3% of patient workload. but it accounts for 30% of litigation payments. So, certainly at AAR, we would be very mindful of the risk management aspect of quality improvement. And that goes hand in hand with, also with reputation, with social media and so on nowadays. You can't really cover up incidents. Word goes out very quickly. So there is that. And if you're investing in healthcare, you are to a large extent investing in the reputation of that organization. The second thing I'd say is that for companies that invest in quality, I would say definitely in my experience, and I think the same. I'm sure Robert and Penina would agree with this, is that they also face lower recruitment costs, and this is important around the world, including the UK, but particularly important in emerging markets, where availability of staff is a barrier to growth. It's a key barrier to growth. So organizations certainly like AAR, like Avenue, as we expand, it is not the same barrier to our growth as it is for other organizations that do not take quality as importantly as they should. And then the final point I'd make, and I could talk about this for quite a long time, but the final point I'll make is, we often hear about, well, we can't afford quality, or quality is too expensive. I would almost say the opposite. Like I come from an engineering background myself, and I would, in my experience, and I actually come from my degree as an engineer. But I would say that my observation of doctors and clinicians is that when there are no guidelines, when they are not sure about what to do, they do more. They order more tests. They keep patients in for longer. They prescribe more drugs. They do more observation. So actually, I would say that the opposite of waste is quality, or the opposite of quality is waste. And that by more standardization, by removing these things that do not add value, we are actually reducing our costs. So quality goes hand in hand with higher performance, with higher levels of efficiency, with better cost reduction. I would say, to answer your question, like how do financial people see this? If I take myself as a typical financial person, is that quality is more and more important. Financial people, while they may not understand all the minutiae the way the people on this line, on this call understand it, they do understand that quality is about value, it's about risk management, it's about increased efficiency, and it's about more valuable companies. Thanks a lot.
Thanks a lot, Emmett. This was very important point to me and to us, because we wanted an opinion which is not biased. We wanted another opinion from people, from the person who is actually in a slightly different field. And that's great that we got your stamp of approval, that it really does impact your bottom line, the quality investment, they really do have impact. Thanks a lot. Now we are moving to our question and answer session. And as always, we have to stay a little bit longer, so sorry about that, probably another 10-15 minutes, because we have lots of questions, but thanks to our experts who actually already typed their answers in the Q&A section. So those who typed their questions, please have a look, but still let's have our discussion, which is always so exciting. So the first question, actually the most frequent one, is there a recording and can you share the recording? Yes, there is a recording, the recording of the webinar and also of the streaming on YouTube. We have shared the link in the chat, and also you can share it with whoever you want, with your colleagues and friends. You can post it on LinkedIn or wherever you want. Please feel free. And the second thing, we will share also some materials after this webinar, the way we usually do. So once you registered and attended, you will get the recording and also all the presentations of our speakers. So I'm answering all these questions in one go. So the second most common question, actually, and I invite all the experts to participate, was about the costs. So I'm sure lots of our attendees today, they are inspired. Probably they would like to do their own cases now and also get the evidence and also get improvements and also then calculate the avoided costs or profit. So costs, how are they calculated? Maybe you can give examples or give some tips, advice. So how to calculate costs of the intervention and also how to calculate the avoided cost to do it right. What possible mistakes can happen? Some advice, tips. Who would like to be the first to take this question? Very practical one.
I can take that one just because I think we have it fairly clearly calculated. You know, implementing clinical decision support had a very clear, you know, development related cost for our EHR that is very quantifiable. The pieces of it that are harder to quantify is that there's a lot of culture change around that, you know, operationalizing a new workflow in your branches. And so I think, you know, the way we look at it is like sort of take 30% of the salaries of the people who are, you know, implementing that workflow change, and then do that over a period of time. And I think that can give you sort of a rough estimation of how much investment there is. And I think you always also need to build in some kind of leadership management costs, right? So it takes the time of the most senior leaders at the organization and is a distraction in order to implement big projects like this. So I think that's what I would do, is factor in staff time costs, leadership costs, in addition to your itemized project costs.
Thank you very much. Javier?
Yeah, just to add on that. So cost for us is specific what the project needs to do. We talking about, you know, developers, training, and hours of training. We have also some external people to come in to help with the project. So very simple the way we analyze the cost, and then the return. And there was a question about the financial amount that we get back. I think for us is more direct in terms that it's a subscription model. So we have a lifetime value and a churn. So we see per income level what the churn rates are and how we increase or decrease the lifetime value. So in this case, what we're seeing is low income people have higher churn rates, I mean, because of the economic difficulty or the financial struggles. And we see as we were switching also how that churn will change. And so that's how we measure the cost and what's the potential outcome for that. And if it makes sense, the investment.
Thank you. Thank you very much, Javier. So actually the next question is again a little bit connected with starting this journey, like how to pick up an area to focus on based on the risks or what. Like say I'm a hospital, I attended this webinar and yeah, I'm excited, I'm inspired. I want to also to have an impact on my financials by quality investments. How to pick up an area again, what tips, what advice can you give?
Maybe I can come in here, Julia. So
yes, please.
Yeah, so maybe it's not answering the question absolutely directly in terms of an area, but you know, I sit on the board of a holdco, and one of the hospitals in our group, you might remember, about 5 years ago, we asked IFC to come in and do a survey under Health IQ. And I think we scored like 23% or something terrible like that. And I don't think it was that the hospital was providing bad quality. It was just that we didn't have the formal systems in place there. But for the board, it was a real wake-up call. You know, whatever it was, 25, 35%, it was shockingly low. And we put a lot of investment into, you know, just getting our act together. And about 2 or 3 years later, you guys came back again, and we'd moved from 25, I think, to 60 something percent. And now we're looking at JCI accreditation. So going from, you know, almost zero to looking at JCI in 4 or 5 years. So I think for, you know, different things, I guess, work for different organizations. But for our hospital, just having that discipline of having, the IFC assessment, which is based on JCI, it's like JCI light assessment, and doing it in a scientific way, and building that into the quality improvement plan with board oversight, that worked really well for us. And by the way, that particular hospital, we didn't see our profitability go down during this period. In fact, quite the opposite. Revenue and profitability have gone up year by year as our quality score went up. So maybe a slightly indirect way of answering the question, but that's what worked for us in let's say real world. Yeah.
Thanks for sharing, Emmett. That sounds great. Emmanuel, I see your hand, and I think Penina was the first. So then over to you, Emmanuel. But first, Penina, thanks a lot.
Sorry, maybe I'll start because I've seen the question of the costs, first of all, addressed to me. So I want to make it clear that you cannot improve what you don't measure. So your decisions are guided by the data that you have at hand. So that is where you start from. You have to put in a system of monitoring clinical incidents, and that is what informs you of areas that you're not doing very well. And that is how you pick up on a project that you really want to work on to improve your quality of care in your organization. So on the cost for Avenue Healthcare, someone was really interested in that. And I'll just mention that when we continuously measured and noticed that we were having increased numbers in patient falls. 3 of them, we just picked 3 of them, and that was the month of January to March. And out of the 3 cases, it costed us about 25.8 million Kenya shillings. Convert that to USD. Kenya is trending at 140 shillings right now. 20 million alone was used to pay out of litigation. We are taken to court because a patient is not happy. Relatives are not happy because their patient fell in our hospital, and which led to a sentinel event. Sentinel event, the definition of that. Either you lose life or you lose a major organ, or both. So 5.8 million Kenya shillings was used to take care of these patients because they have fallen in your hospital. So you have to take responsibility as a hospital to cater for the cost of management for those patients. I hope I have answered the question. Thank you.
Thanks a lot, Penina. Yeah, and basically, I just wanted to sum up because the answers of our experts were very relevant. So it all leads to diagnostics, basically. What Emmett said, what Penina just said, incidents show you certain areas which are risky. External or internal assessments, which you do as a self-assessment or invite an assessor to do, or they also show you the risk areas, the priority attention areas. And right there, you can start your project and focus on this, because spreading efforts sometimes do not give you enough attention to a specific problem. So try to focus and not to embrace everything at a time. Manuel, you wanted to say something?
Yeah, so just quickly, Julia, you mentioned about it. Your second question was related to how do we pick that area. So we focus mainly on our hospitals. We focus mainly on high risk areas. We look at the areas that will cause major impact in patient safety care. And what we did in our hospital, we piggyback to the campaign, this international campaign called Choosing Wisely, what is basically focused again on patient and safety, quality of patient safety care. With that in mind, we'll look at what were those recommendations given by multiple societies, Kenyan societies and international societies. And we looked at what will that be in terms of implementing those recommendations in our hospital. We pay attention a lot of diagnostic imaging, medication management and medication prescription errors. We looked at also procedures in surgery, and we looked at lab medicine and pathology. So that translates a lot into what we achieve. And obviously, like everybody says, high performance, less mistakes, less errors, and everything together at the end is patient satisfaction and better outcomes.
Thanks, Manuel. Great point. So next question also is partially related to costs. Our speakers today were talking a lot about IT solutions. Of course, IT solutions help a lot to structure the processes, to improve patient safety, etc. However, for many facilities, especially in emerging markets, there is still a psychological barrier. So IT solutions seem very expensive. So what advice can you give to our hospitals how to basically jump into this area of big expenses, and how not to lose motivation, because first it gets really bad and because you spend a lot of money, how not to lose motivation before it gets better, how to not to lose faith into this, and maybe there are some compromise step-by-step solutions or whatever, because this is something which is very common these days, unfortunately. Not everyone can afford good IT solutions.
I could mention, so I mean, great, because always you get scared when you're going to start the investment or approve the project. So what we do typically is we differentiate disruptive innovation versus process improvement. So we have two lists. So one is what I call process improvement. You know, it's small changes that I mean, you will see smaller changes, but if you get all those together, it gets to a much higher, a very big improvement. And then we have the disruptive ones that, you know, we have a lot of resources, a lot of investment. So we typically take 2-3 on the disruptive and radical ones, and then we have like 25 of the other ones per year. So we get motivated by the process improvement ones as we're seeing how things are changing, and then every 3-4 months, you know, as we accomplish a new disruptive, and also we don't, I mean, if you invest too much in too many initiatives, you might get lost or waste money because of the decision that you have to take. So always taking small bets with big investments, and then do a lot of small ones.
Thanks, Javier. That's actually very useful to know. Yeah, and these little changes, like quick wins, you really get motivated. And also, this is something which shows evidence. Yeah, I'm going up the right track. Penina, please.
Yeah. So to add on to that, even as at now, I would not say that Avenue Healthcare has really got the systems that are required, or the ones that we wish to have. That remains our wishful list, because we are not able to afford all the systems that we really require. But I would like to encourage, you know, the ones who are asking to focus on high risk areas, you know, high volume, high cost. Those are the cases that you want to look at first when you're putting up your quality metrics, and you need to be transparent in measuring and reporting and, you know, addressing the gaps that come up. And, you know, just all this should be driven by leadership, you know. And once this is made a continuous thing within the facility, then it becomes a culture that everybody gets into. But also transparency is one thing that have worked for us, because, you know, when you have an incident, you don't focus on an individual, you focus on a system. And once you've been able to address the system issues, then I think that is the way you succeed.
Thank you very much. So, Robert, any tips from you? What worked for Panda?
Yeah, I think there's one thing that unlocks all of your other layers, and that is getting a cloud-based electronic health record. I think organizations need to decide when they're going to do that, because it is a big investment. There's no sugarcoating that. It's the computers and the mouse and the keyboard and the monitor and the server, and like it's a big, heavy investment. And then it's training staff to do things all on a digital process. That is expensive, but once you do it, it unlocks all of these other things, whether that's clinical decision support or patient engagement, or, you know, better monitoring, easier reporting to the Ministry of Health. There's so many things that it unlocks. And so I think you just need to know when is the right time to make that big jump. And then all the other pieces are much smaller and more modular that you can layer on.
Thanks a lot. Yeah, this is really a big jump. Every time IT solution is involved, it's a big jump, but it's definitely worth it. Thanks. That's a great point. So last call for any comments from our panelists today, and we will be wrapping up because unfortunately we're running out of time. Although it's such an interesting discussion, we could go on forever. So anyone else wants to give an opinion on this? Seems no. So, Penina, you wanted to say something, no? Because you're unmuted.
For me?
Yeah, it's fine.
Yeah,
Yeah.
so really nothing, but I just want to address the people who have been asking how they can be able to monitor this data, if there is any tool to be used. Yes, we have a lot, but of course you have to choose what works for you and what addresses the problem that you have at the moment, because what works for my business might not work for you. But all these tools are available. You can always share.
Yeah, thanks a lot. So we still have lots of questions arriving. We will be posting answers in our community of practice on Facebook for those which we couldn't cover today during the due to the time limit. So please join our community of practice. Also, you can email us if you still have some questions. So yes, there will be another round of contest, hopefully by the end of this year. So if you are interested to participate, you may start considering cases how quality improvement in your facility converted into avoided costs or growing profit, so that you can present them by the end of the year, because gathering statistics takes time. So the earlier you start, the better. If you want to join our benchmarking initiative in IFC, please let us know. We included this question, I think, into our questionnaire survey on exit. So please just leave your email and we will contact you with more details how to participate and tell you about the service. So thanks a lot for joining today. I hope you enjoyed. It was great fun today to interact with you, seeing your questions, seeing your comments in the chat. Have a great day, everyone.
Thank you.
Thanks a lot to our wonderful panel today. As always, you are
Thanks a lot.
stars.
Thanks, Julia.
a lot.
Thanks, everyone.
Bye-bye. Thanks.
Bye.